Thank you, Dr. Suranjit, for this very warm introduction. I remember when I met you in the NetScan and when you took over, dear friends, it's a great honor and pleasure to be here. And I must tell you that it is my great honor to speak on a topic which Chairperson has introduced fabulously. This is the year of centenary of insulin. And we are going to discuss what are the landmark trials in insulin, which has greatly impacted the clinical practice. So now, dear friends, I must tell you that I wanted to look to the what are the impacted clinical practice. I found this definition. The landmark trials impacting clinical practice are those, number one, who are an important stage in the development of a molecule or a turning point in the history. Number two, it has mid-course correction of the history and also on which the further improvement depends. And the third, these trials are noticed and looked by everyone working in various fields on insulin and diabetes, and this contribute to patient's outcome. Taking that into view, my dear friends, I have in the next 25 minutes or less to present a few things about the landmark trials. Dear friends, the landmark trials to my mind are the DCCT, the EDIC trial, the UKPDS and the UKPDS follow-up trial, the Origin trial, the Accord trial. Little less in order and importance will be Kumamoto trial, but it's a great message and impact in the clinical practice, which has been reiterated this year about 3 months back, which said that what is important in diabetes management is the insulin management in the first year of diabetes. The DEVOTE trial, the BRIGHT and the CONCLUDE trial, the ONSET trial. But what is most important is that can we reverse diabetes with insulin early on? I'll talk about that particular trial with one slide, the reversal, quote unquote, cure of type 2 diabetes mellitus with early insulin, not more than 2 to 4 weeks. And we get benefit for up to 5 years. And of course, few trials which I'll just touch upon, like VADT trial, etc., which I'll have no time to go in detail. This one is historically important, my dear friends. This is the first trial, the first RCT published in diabetes medicine. And you know, it's a very small trial, but it led to the use of synthetic insulins. It's a comparison between the pork insulin and the human insulin. And it suggested that in the absence of insulin antibody level, there is a simple pharmacokinetic difference between the human and the pork insulin. We may be in our structure closer to pork, but there's a difference, and human insulin stands out head and shoulder above any animal insulin, including pork insulin. Mind you, friends, this is the first trial where the use of the supremacy of human insulin was to be established beyond the animal insulin. I've just brought it for the point of view of history, because the first RCT, small, but it laid greatest impact, the use of synthetic insulins. And you know, from that day onwards, it is said there's a relentless advance against relentless disease. That means the insulin advances from that day have been relentless and against a disease which is equally relentless. Dear friends, we'll come to one of the most important trial of insulin, which has impacted the scenario maximum. This is the DCCT trial. Dear friends, I'll be putting the points which are not ordinary. So even if you know the trial, I like you to kindly look into it and just give it a listen with a very casual manner, because I'm just speaking to you that the diabetes control and complication trial opened the floodgates of adequate and strict glycemic control, because it showed that in the intensive arm, vis-a-vis the conventional group, we found that if you want to establish a blood sugar level between 70 and 120 in type 1 diabetics, and postprandial 180, and at about 3 a.m. once or twice in a month about 70, and HbA1c 6.5 and below, one has to take about 3 injections of insulin a day or even more. One has to do almost 4 blood glucose tests daily. Patient has to be hospitalized for initiating treatment and has to undergo comprehensive education program and has to frequent dietary instructions, and after that monthly clinic visits. Dear friends, this is contradistinction to a conventional treatment group where it was only objective was to avoid symptoms of hyper or hypoglycemia, only 1 or 2 insulin injections per day, daily self-monitoring only once, initial diet and exercise education, nothing beyond that, and one can visit once in 3 months. Dear friend, lo and behold, this necessity has clearly established before us that the intensive therapy group reduced and maintained H1C at a lower level. It was between 7 and 6.5. And it showed in both the cohort, in the primary cohort and secondary cohort, there's a great reduction of microalbuminuria, retinopathy, and neuropathy. Even though it looks simple, the message is great, the impact is great. It says 2 things. Number one, that if you control the blood glucose intensely, and that's why we have used the word here, intensely, then you find there's a great benefit of the complications. Needless to mention, treatment of diabetes is in a great way the treatment of complications. It also shows the number of visits are important. Please look into the hidden aspects of the study. The patient who goes to doctor maximum number of times or in the appointed times. Here the patient was going every month, contradistinction to people who are going every 3 months. The tenacity of purpose was very intense in the first group, vis-a-vis not so intense in the secondary group. Therefore, the impact of this trial, apart from showing that the strict control is of paramount importance, it also shows that one doctor, the physicians, and of course the people with diabetes, child with diabetes, type 1 diabetes, should have that mindset that I will control, maximal control. I will visit doctor in the appointed time. If it is 15 days, 1 month is perfectly all right. And that has given the salutary effect. But there's a small trade-off. The trade-off between the strict glucose control and the hypoglycemia. As expected, there was severe degree of hyperglycemia, but you see the retinopathy has come down. The lower the H1C, the lower the retinopathy. This is a very beautiful slide. And it says, it said that the risk of retinopathy progression, and retinopathy is equated to diabetic complications. Similarly, microalbuminuria progression is related to H1C. Now, as the H1C goes higher and higher, from 5 to 6, 6 to 7, 6 to 8, the retinopathy and microalbuminuria goes higher. It looks very simple, but put your hand on the heart and say, how many of us and how many of our patients do this practice? So very, very important message, impact for this trial, that we have to bring down the H1C as low as possible. Therefore, the impact are 3. Number 1, intensive therapy can improve glycemic control significantly. We have in the armamentarium insulin, which can bring down the H1C to 6.5 and below. It can reduce the occurrence and the progression of the microvascular, not the macrovascular. Macrovascular is multifactorial, but microvascular complications can be controlled. And there's a continuous relationship between the glycemic control and the risk of developing retinopathy and microalbuminuria. The risk of hypoglycemia goes up. In this study, it was almost 3-fold. Nevertheless, I repeat, nevertheless, intensive therapy did not affect the quality of life, the QOL, the cognitive function, and the cardiovascular death. There was hypoglycemia, which was acceptable. I remember Robert Holman, whose father was a governor in Tamil Nadu. He used to say there was hypoglycemia, but take it or leave it. I mean, they all carried out very well with minimal therapy. But dear friends, the message I want to give is the message that is hidden in the EDIC study. Epidemiology of diabetes and intensive intervention and complication study. Epidemiology of diabetes intervention and complication study. Dear friends, this is again about intensive insulin treatment, but in different manner. The EDIC study showed it was these city patients were followed up for 7 years. The risk factors for the long-term microvascular and macrovascular complications. Prior diabetes treatment was good. Level of glycemic control in this city was excellent. And all patients are advised to take intensive insulin therapy. But lo and behold, it was found that intensive therapy significantly reduced the HbA1c and also maintained it. But there was another group, the conventional group, encouraged to switch to intensive group, and the intensive group, after they were not asked to become conventional, but after some time they lost the tenacity of seriousness and they also became the conventional group. Now it was seen that the glycemic control throughout the trial, both in the conventional group and the intensive group, was little let loose. Instead of 6.5, it was almost up to 8 in the intensive group, and similar to conventional group, because the intensive group has also let loose and become conventional. But what is most important, that the microvascular complete reduction was ingrained again in the intensive group. You find the intensive group, in spite of H1C going up to 8.75, almost up to 9, the complication profile was much better. And you find, compared to the conventional group, the earlier intensive group, who had the early aggressive control, in spite of the blood glucose going loose and H1C becoming 8.75, 8.9, they still maintain a lower incidence of the microvascular complications. Therefore, in the microvascular complications, the ED group, at the end of 4 years, RRR, relative risk reduction, was 76%. Microalbuminuria at 8 years of conventional control follow-up was 59%. Clinical albuminuria, 85%, and neuropathy at 43%. Look at these numbers, and this shows that early aggressive control is worthwhile. It again echoes what has shown recently, that the first year, I again remind you, this is the 2021 message, the first year diabetes control. The patient sits before you. What you do for the first year is of paramount importance. There was severity risk reduction of intensive therapy in 10 years after DCCT, and you find that the risk of any CVD events here, and the risk of non-fatal MI, stroke and death from CVD given here, which is very significant. Therefore, the impact are glycemic control in the intensively treated group, equivalent to that of conventional treatment group in the follow-up period. They have let loose, they become equivalent to the conventional group. However, reduction in the microvascular and also reduction in the macrovascular does continue. And in intensively treated group, it persists. That is the message. This is called the legacy effect. All of you know it. I will not carry coal to Newcastle. This is the metabolic memory. It is believed that the good metabolic control gets imprinted in the mitochondria of the patient cells, and that gives the long-term effect of early intensive glucose control, can give a long-term rates of microvascular complication, which are very low. We'll change gears and go to the type 2 diabetes. Again, I'm taking a very well-known trial, but I'll present it differently. I prepare differently. It's the UKP trial, United Kingdom Progressive Diabetes Study. And you know, this is told today as the compendium of type 2 diabetes in the world. It is so famous a study. It's a 30-year study, 30 number of year study. It started 20 years with the intervention trial from 1977 to 1997. There were 10-year follow-up beyond 97 to 2007, and further follow-up is coming. In the first, and this was the intensive control time. This was the post-trial monitoring time, when there is control was not very great. But you know, the annual follow-up of the survivors was clinic based for the 5 years, and the questionnaire based was the last 5 years questionnaire based. The median follow-up was 17, but the real follow-up was almost up to 30 years. Now, what did it show? I will save time not going to the numbers, but you find that whenever they had the intensive group, in contradistinction to the conventional group, both the arms, it was observed retinopathy, nephropathy, and possibly neuropathy are benefited by lowering blood glucose levels in type 2 diabetes in the intensive therapy. And mind you, they had urea and insulin, and sometimes they had metformin and intensive group metformin. Those who were obese diabetic, that metformin with insulin. So insulin was the fundamental treatment in the either group, which achieved the median H1C of 7, compared with the conventional therapy, which had a median H1C of say 7.9 or 8. The overall microvascular complication reduced by 25%. This is Bibi Tripathi Hall, my teacher, my mentor. He used to show the hands like this. Mohan is here, Professor is here. That in the 7 and 7.9 matters. How it matters? It matters in 1/4. So, my dear friends, even little lowering of H1C gives you maximum result. There's a continuous relationship between the risk of microvascular complications and glycemia, such that every percentage decrease, 9 to 8, 8 to 7, 7 to 6, there's a 35%, more than 1/3 reduction in the risk of complications. That is the message from the study. And you know, no significant effect of lowering blood glucose on cardiovascular complications observed. Yes, but even though it was not a severity trial, did not show the 3-point, 5-point MACE, heart failure will come a little later. But there was a 16% reduction in the risk of combined fatal and non-fatal myocardial infarction. Not small, 16% reduction in the combined fatal or non-fatal MI, and the P was significant at 0.05, which is significant. Epidemiological analysis showed a continuous association between the risk of cardiovascular complications and glycemia. The sugar is high, the severe complications high. Therefore, for every percentage point decrease H1C from 9 to 8, again 25% reduction in the diabetes-related death, 7% reduction in the all-cause mortality, and 18% reduction in the fatal and non-fatal myocardial MI. So, dear friends, this study is great to my mind, and this is a compendium of type 2 diabetes and its complication even today in 2021. Now comes the real pudding of the study. Now look at here. UKPDS follow-up study. It was found that all surviving. There were about 3,300 patients were enrolled in the post-trial monitoring program on September 97 for 10 years, 2007. And now this was again similar to EDIC study. The control was not strong. They all came down to the conventional group, and they wanted to see whether the earlier control had a long-term effect on the macrovascular outcome and, of course, microvascular outcome. Now, you see, these are the groups I told you, the SU insulin group and the metformin group and metformin intensive group also received insulin. And, I'll make a long story short. This is published in UKPDS 80, number 80 study. You look at the any diabetes endpoint. I have no time to get into it. There's a difference between the SU insulin group and the conventional group. You see the event rate is lower. Look at this. The conventional therapy and SU insulin, death from any cause is lower. Look at this myocardial infarction, it is lower. Look at the microvascular disease is lower. And if you look at the benefit of the early tight control, what I'm calling today first year control, UKPDS, and 10 years post-trial follow-up period, you take any diabetes-related endpoint, at the end of the trial was 12%, at the end of 10 years beyond strict control was 9%, comparable. The reduction in the trial end of the complication 25%. Here it was almost 24%. By microvascular disease, 25% reduction, 24% even after 10 years in the group control. The myocardial infarction 16% reduction, as I showed you little before, it was to 15%. So it summarizes to say that in type 2 diabetes, if you control early on, great. If your control early on is severe, then you get the benefits even after many, many years. So UKPDS 80 showed extended effect of improved glycemic control patient with a newly diagnosed type 2 diabetes mellitus observed up to 30 years. 30 years. Benefits of intensive control in type 2 diabetes was sustained 10 years after cessation of the randomization of intervention, that is up to 30 years. Original intervention trial conclusively demonstrated benefits of glycemic control, reducing microvascular risk. Our risk reduction of the MI and death from any cause emerged only during the post-trial follow-up, because we have to have number of years more and multifactorial, which we get this. Strengthen the relationally for achieving optimal glycemic control early and indicate emergent of long-term benefits on cardiovascular risk. Dear friends, I will just change the gear here and go to a very simple study, but highly impactful study, is the Kumamoto study. The Japanese Kumamoto study, the number of patients were much less, but there was a primary intervention cohort and the secondary intervention cohort in the Japanese. The conventional group received once or twice daily injections of intermediate acting insulin. Intensive group received short acting insulin, say human insulin or Arpidra or Actrapid, received 3 times, and intermediate acting insulin bedtime. So something like a basal bolus in the intensive group. Lo and behold, you will find in the conventional group, the patients had retinopathy much more compared to the intensive group, where it was much less. Dear friends, the development of the and progression of the diabetic micro complications in the conventional group was high, 68% vis-a-vis 20%, 74 less than 20. And the urinary albumin excretion 100% less than almost nil. So this shows both in the primary and secondary group that development of the progression in the intensive glycemic control group can delay the occurrence, the onset, and also delay the progression of the early stages of diabetic microvascular complication in Japanese patients. I will stop here, but I'll discuss 1 minute on this. This is the study I was referring to. I have not brought much material to show you because it is well in before of us in the literature. Same in the area of Kumamoto. It was shown you have a short-term intensive insulin therapy in the young diabetics and control the hypoglycemia. The beta cell function improves, insulin resistance improves, and these people can achieve a long-term drug-free glycemic remission. Drug-free glycemic remission at the end of three months, about 2/3 of the patients were drug-free. They were not getting any longer insulin, but they were in remission. At the 6 months, 60% were in remission. 12 months, 50% remission. At the end of 2 years, 42% of remission. So, dear friends, this is a highly impactful study on insulin, that if you give to the young onset type 2 diabetics of hyperglycemia earlier insulin, for how long? Not long, 2 to 4 weeks, you can reap the benefit of the end of 4 years, up to the end of 2 years, having a control for life. Dear friends, I do understand that we have to close, so I'll be a little faster. Give me about 5 minutes extra. I'll just bring home to you 2 trials on the cardiovascular outcome. One is Origin trial, and our friend Ramchandran, my classmate, was the head of the Origin trial, and it was a study on the glargine, and it was an outcome reduction with an initial glargine intervention to Origin. Now, what was the objective of the Origin trial? To see whether the new or recently diagnosed diabetes or IFG or IGT or with additional CV risk factors, if you give them glargine, follow for 6 years, what is the effect of the insulin glargine on the CV outcome? And that time there is a fear of cancer, whether it can produce cancer. So, dear friends, Origin trial was based on the CV outcome, whether insulin making the CV outcome worse. I'll repeat again, whether glargine will make the CV outcome worse, whether they will develop cancer. Now, insulin glargine was added to nil or maximum 1 oral agent. In the standard care, there was 2 OADs, no glargine was used. You look, when the glargine was given, the blood glucose control was absolutely fabulous, 79 to 104 versus 103 to 142. And beyond anybody's imagination, glargine showed new diabetes developed in less number of cases, 24.7 versus 31.2 in the standard therapy. And there's attenuated effect noted even after second OGTT. And in people who are at risk for the future diabetes, the pre-diabetes people, 6 years of basal insulin glargine titrated to normal FPG and reduced the incidence of the diabetes. Of course, with those who are on glargine, the weight went up to 1.6 and the BMI went 0.81. And there was little bit of hypoglycemia. But what was important was the implications, what I want to bring to you, compared to the standard therapy, type 2 diabetes, IGT or IFG, using once daily basal insulin to target FPG of 95 or below for 6.2 years, take 6 years, maintain near normal glycemic control. It has neutral effect on the CV outcome. It was not CV enemy. The effect was neutral and cancer was not found. There was slow progression of dysglycemia. I'll repeat twice. Progression of the dysglycemia. There was modest increase in the weight. And definitely basal insulin glargine slowed the dysglycemia production. It is again shown here that in approximately at the end of 6 years, the clinical trial designed to assess the effect of the treatment with insulin glargine versus standard care, it showed very clearly the insulin glargine, when used to target FPG for more than 6 years, has a neutral effect on the cardiovascular outcome. It is cardio safe and it is better for the dysglycemia, and it also reduces severe risk factors. The insulin glargine, when used to target FPG for more than 6 years, has a neutral effect on cancer. It has good effect on the dysglycemia, severe risk factors, and was cardiovascular friendly. Dear friends, I have no time to get into detail. The 3 take-home from origin trial: glargine has neutral effect on incidence of cancer and severe risk factor. Use of glargine with a sustained reduction both H1C and FPG, and glargine may delay the progression of type 2 diabetes, pre-diabetes. Dear friend, I will not spend time on this. It's a devote trial. It's not equal, trial with the equals. It is the trial between the degludec versus glargine U100, not glargine U300, and it showed it has a cardiovascular benefit, and it showed that there is severe safety of the degludec. We use it today plenty as alone or as a co-formulation, and we found the 40% lower incidence of hypoglycemia, but it has a great cardiovascular benefit. Last 2 trials I'll allude to is BRIGHT and conclude. This second generation basal insulin trials. It was between the BRIGHT, the Toujeo insulin, and the degludec insulin, the degludec versus glargine U300. Now it showed that the degludec has little age above the glargine 300, except in the titration period. In the titration period, the hypoglycemia was less in the glargine U300 Toujeo. Other time, the hypoglycemia was little more than the degludec. So degludec was little scored above than that. So this is the comparable. I will not take you details because already 8:35, and I'm acutely concerned that I should finish in time. Now about the few trials, about the trial with the bolus insulin like FIASP trial, the rapid acting insulin trial. There are many trials, but why I'm showing this, because during the time of the COVID-19, we have used FIASP very, very sincerely. Large number of patients to bring down the hyperglycemia early on. We have been benefited. And this was the onset trial, which showed that in type 1 diabetes, this FIASP fast-acting aspart can be more physiological and can replace early insulin secretion, better profile for the pump therapy. And also compared to insulin aspart, it has twice as fast onset of appearance, which is required in a case of cancer, COVID-19 diabetes, and 2-fold higher insulin exposure within the first 30 minutes. I will not go into details of it to save time. And to conclude, dear friends, over the years, various landmark trials have used. I have got about 79 trials. Bansi, I'll talk about on some other time. But I must tell you that over the years, the various landmark trials have provided. This is another trial called the intensive trial. You know what it was? It was a trial to approve that the fast-acting insulin aspart, FIASP, was beneficial in children. So I don't have to, this is not a landmark trial. I'm describing it to you. 79 other trials have got off my cuff. I will not go into details of it, but I'll just end by saying that that over the years, various landmark trials have provided useful insights into management of diabetes. UKPDS, widely conceived as a mother of all trials, the compendium of all the trials. With regard to the insulin landmark trials like Necessity Edict, Wikipedia's follow-up, we know today that the early glycemic control with insulin matters. We know from the origin trial and other trials, they are cardiovascular friendly. They do not produce cardiovascular onslaught. They're cancer friendly. There are many other smaller trials which we'll discuss some other time. So I'm extremely happy, my dear friend, on the 100 years of insulin discovery to present to you the few landmark trials. Please remember the take home, diabetes is bad because of complications. The faster glucose control matters, and that gives the longer life, complication-free survival, and gives you the full value of what you spend in the first year. Thank you very much. And thank you, Suranjan ji and Jishi Reddy sir for tolerating me. Thank you, my dear audience, for staying with me. We can have few questions. Bye-bye.